Hereby, I open this academic ceremony in which Marlena van Munster will defend the academic thesis Defining and Professionalizing the Role of Parkinson Nurses, Competency Development for Personalized Parkinson's Care. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you, Pro-Rector. Thank you, Corona Committee. Thank you, family and friends, and everyone else for coming. In the following 15 minutes, I would like to present the results of my PhD research entitled Defining and Professionalizing the Role of Parkinson Nurses. Parkinson's disease is a disease composed of motor and non-motor symptoms. It has a highly individualized disease progression. It requires thus long-term care and really complex care. The prevalence and impact of Parkinson's disease is significant. It is estimated that 1.2 million people are affected by Parkinson's disease in Europe. From 1990 to 2021, we saw a 60.7% increase in prevalence, and that is not only related to better diagnostics, but also due to an aging population. It is expected that we will observe a doubling of patient numbers within the next decade, and the annual costs of Parkinson's disease in 2010 were estimated at 13.9 billion euros. In 2010, I'm citing these numbers because unfortunately we don't have any more recent numbers for Europe. However, we can expect that since then the costs haven't lowered but increased. Care challenges arise from an increasing demand of Parkinson's care due to an increasing number of patients, and we can already, as of today, observe overburdened healthcare systems. For example, in 2018, experts called for action to fight the so-called emerging Parkinson's pandemic. And also the WHO mentioned in a technical brief that there is an urgent public health response necessary to meet health and social requirements of people with Parkinson's disease. So we can conclude the need for sustainable healthcare models is really urgent. Well, there are still, despite all of those challenges, some good news. We already know what is needed. We are not starting from zero. We know that integrated care structures, so healthcare structures working across different sectors and settings of care, multidisciplinary team approaches involving different professions and prioritizing interprofessional decision-making, and person-centered care models following multidimensional needs and quality of life of patients and placing the patients as persons at the center of every care decision help to improve the effectiveness of healthcare structures. Well, despite that, there are also some bad news. We don't know right now who should be responsible for all of this. In an international expert guideline published in 2020, Rudder and colleagues recommended that specialist nurses are especially useful for implementing such person-centered care structures and facilitating the improvement of the so-called for what healthcare actually should be delivered for the persons being affected. However, those specialized nurses are rarely present in any healthcare system worldwide. And that was, in my opinion, an interesting observation. How could that be? On the one hand, we have this expert guideline recommending those specialist nurses, and on the other hand, we are lacking professionalization for those nurses. So I thought, well, maybe we should rethink competencies in Parkinson's care, and that led me to the formulation of my research question of this PhD research. How can the role of so-called Parkinson nurses be defined and professionalized to advance more personalized Parkinson's care? I explored this question through 4 sub-goals, which I will dive into later in this presentation. So, how did this PhD trajectory go? I started and deliberately decided to start at the desideratum of personalized Parkinson's care, placing the people's perspective at the center. And in order to make that perspective visible, I first of all set to define this perspective by exploring patients' perspective on quality of life, a really central outcome in person-centered care planning, and exploring their perspective on Parkinson's care. I then aim to identify different facets of Parkinson nursing. What is already there? What do we already know? Then I theorized how Parkinson's care can be advanced through professionalizing the role of the Parkinson nurse. And last but not least, I explored the perspective of already existent Parkinson nurses on their role of the delivery of specialized care. And all of that led me then to defining and also hopefully professionalizing a little bit the role of the Parkinson nurse. In this PhD research, I facilitated and used different methods, mostly qualitative methods. I conducted systematic reviews, interviews, focus group studies, and also online surveys. But I also used some quantitative measures through conducting a meta-analysis, and also some theoretical work was done in this thesis. So, my first sub-goal was to come from experience to expertise. How can patients' perspective shape the Parkinson nursing role? My first publication was a systematic literature on qualitative studies on patients' perspective of quality of life. As I already mentioned, a really central outcome in person-centered care planning. I conducted a meta-synthesis of the included studies, and what I observed in that study was that patients' experience of quality of life goes far beyond just disease-related aspects. Person-centered care requires thus attention to personal context, not just seeing the patient, but also the person behind the disease. And we can conclude from that Parkinson nurses must have a holistic view on patient needs, not seeing them just as being affected by a disease, but also as part of social life, as persons living in their environment, and also as persons going through a really individual disease experience. In my second publication, then, I conducted a cross-national interview study, which was really huge. I interviewed 113 patients and analyzed the data from that through an undirected content analysis. Patients attributed various roles to healthcare providers, and interestingly, in this study, we involved patients from the healthcare system where Parkinson nurses were already present, and healthcare systems where Parkinson nurses were not yet present. And from that, we can see that specialist nurses take on some roles that are otherwise not taken up by other healthcare professionals. For example, they are educators, and really importantly, they are a companion for the patients through the disease experience. We see also that patients in countries where Parkinson nurses are not present yet express a desire for better care coordination between their care providers, and we can conclude from that Parkinson nurses are an anchor point from the patient's perspective. My second sub-goal was then to come from practice to profession, observing how a Parkinson nurse is on the rise. And I did this through conducting a systematic literature review on nurse-led care models and conducting a meta-analysis of randomized controlled trials comparing nurse-led versus standard care with a central outcome of quality of life. And in that publication, we can observe that Parkinson nurses take on a plethora of roles. They take on many, many different tasks which contribute to person-centered care. For example, helping to proactively monitoring the care process, helping to monitor other aspects of healthcare, navigating the patient through the healthcare system, providing information not only to patients but also other healthcare professionals, and also taking on various other activities that are not yet defined in existing frameworks of person-centered Parkinson's care. So we can conclude from that Parkinson nurses are key players in person-centered care. However, we have sort of unclear role descriptions yet, and that might be a barrier to their establishment. So my fourth sub-goal, and I'm deliberately now continuing with the fourth sub-goal, was to come to a point where we theoretically frame that the future should be personal. Parkinson nurses are key to a better healthcare. And that was done by a publication conducting a scoping literature review on care priorities for Parkinson's disease, following a line of reasoning approach, postulating implications for the definition of the Parkinson nurse. Because, as we already saw in the previous publication, there are already some care models and studies out there facilitating the use of the Parkinson nurse. However, we lack a theoretical framework. And based on that study, the scoping review, we can conclude that personalized Parkinson's care can be advanced through professionalizing the Parkinson nurses, one, as suppliers of comprehensive care. They are key to enabling such care, and they're really importantly self-management supporters to patients, care partners, and other professionals. So the conclusion from this publication was that Parkinson nurses should be trained in at least 4 modules, becoming experts in the disease, being a health coach to patients, developing skills and knowledge to assess patient outcomes and identify personal care requirements, facilitate access to healthcare, for example, through developing knowledge about local healthcare resources, and also, if applicable, this is a huge and important part in personalized Parkinson's care, helping to facilitate the use of telemedicine. So, and then I aim to explore this theoretical framework on some insights from within. And the last publications in this thesis were 2 case studies where this theoretical training framework was applied into practice, and nurses were trained according to this theoretical framework. And in 2 publications, I explored the self-perception of nurses. How does their professional self-identity changes when they are trained according to a theoretical framework? This was done through a focus group study, and I explored how do competencies for telemedicine look in nurses when they are facilitators of that and when they are applying such technologies. We can observe from these 2 case studies that Parkinson nurses' self-perception matches, interestingly, the perception patients have about them. They perceive themselves as partners in healthcare. We can also see that they have a self-image of a coordinator who represents the patient perspective in decision-making, so they perceive also some responsibility for representing the patient in decision-making processes. They also have a gatekeeping function, as they are monitors of the healthcare process and coordinators. And they are, if the context is there, facilitators of telemedicine, as they help to educate patients about it and other healthcare professionals. So, how do we then define the role of the Parkinson nurse? Well, the conclusion from this thesis is a Parkinson nurse is someone who has a specific attitude of lifelong learning and openness. A Parkinson nurse is also someone who has specific knowledge, who is part of the multidisciplinary team. How can we foster person-centeredness? What do others have to know about Parkinson's disease? Then, a Parkinson nurse is also someone who has specific skills. They have skills in care coordination, they have skills in handling Parkinson's disease-specific technology, and they also are transformational leaders, guiding and inspiring other healthcare professionals to follow a person-centered approach. Through these skills and competencies, Parkinson nurses fulfill different roles. First of all, they are facilitators, they are advocates, they are civilians, and they are also, and this is really important in person-centered care, connectors. However, professional is maybe not just a label you give yourself, it's a description you hope others will apply to you. So we certainly can agree that professionalization doesn't stop at defining a competency profile. We also have to make sure it's implied in practice. And this leads me to my last slide, where I would like to dive in a little bit on the implications and impact this thesis had. One implication of this thesis is that health workforce development must be based on the question for what healthcare should be developed. What do we really want to achieve? Person-centered care. One other implication is that structured training and continuous professional development programs are needed. Competencies are not just something that are developed on the go, we need to develop them specifically, and we need training programs for that. And professionalization is a mix of evidence generation, building theories, reviewing the literature, identifying knowledge gaps, but also then implementing what we as researchers recommend. And I can proudly say this thesis has pioneered research on the professionalization of the Parkinson nurse. It contributed to international and national collaborations in research and education, and it contributed also to workforce development. In Germany, we have a saying that when there is a problem, you should start solving it in the front of your own door, and this is what this thesis partially also did. When I started this research, Parkinson nursing was an informal training in Germany without any clear career pathway. So nurses could undergo a training, but it didn't really increase salary or formal recognition. In 2021, I postulated the training curriculum I just presented, and a working group in the German Neurological Society was established. I joined this working group, and from that some beautiful collaborations emerged. In 2022, we worked on a synthesis of a German competency profile adapted from the theoretical framework for Parkinson nurses, and we established a specific nursing day at the annual Congress of the German Neurological Society, aiming to increase the visibility of this so much needed profession in Germany. In 2023, we then participated in a decision to reform and standardize existing training courses for Parkinson nurses, and we established a national task force that exists up until today. We founded a WhatsApp news channel for Parkinson nurses to foster professional identity formation and get the nurses in touch with each other. And we published a position paper with a call to action to reform the training of Parkinson nurses in Germany and also increase formal recognition. I can proudly say that we are now currently working on a harmonized training pathway to establish Parkinson nurses in Germany. We will launch a study program, a bachelor program, to make them an even more educated profession in the healthcare system that is in line with the already existing informal training pathway that we have. And we are also planning to transfer the results of this thesis to other chronic diseases and educational pathways in the healthcare system. A wise man, Dr. Jim Campbell, once said, "There is no health without a workforce." And I certainly would conclude that with this thesis, I demonstrated that this statement is super true. However, I would like to add one small word. There is no health without a competent workforce. And with this, I would like to conclude my presentation. Thank you all for your attention and give the word back to the prorector.
Thank you very much for your presentation. We will now start with the opposition, and the opposition will be opened by the chair of the assessment committee, Professor Zwakhale, Professor of Nursing Science at Maastricht University.
Thank you. Dear candidates, first of all, congratulations with your beautiful thesis, and also thank you for the work that you presented. And I really liked your layout, because I remember when I was a nurse, it was a while ago, I wore the watch and the pen, but I can't remember that I ever wore a flower. So I think it's good that it's in the basic equipment of the nurse in your thesis. And I also have a personal interest. As I mentioned, I was a nurse, I was educated as a nurse, so I feel a bit like a nurse. I'm not registered anymore. It still hurts, but that's a sidewalk. And I also had a mother who suffered from Parkinson's disease, so I know it's a very nasty disease, and nurses play a very important role in that. So thanks for your work, and also for the progress that you showed us in the development. But not only congratulations and support, also some critical questions. I would like to address what appears to me is like a lack of clarity still in the research gap, what you identified. Your thesis strongly, and you also as a person, advocate for the role of the Parkinson nurse within this multidisciplinary care team. Yet for me, it's not fully evident why such a specialized role is indispensable in the light of chronic general care that you describe. And you refer to the importance of care coordination, individualized care, collaborations with both specialized and non-specialized professionals. However, these responsibilities align closely with core nurse competencies, as identified, for example, in a CANMAT framework that you probably know. So these apply to all nurses. Could you please elaborate first on what specific evidence supports your necessity of a designated Parkinson nurse for fulfilling this role, as opposed to enhancing these competencies of all nurses to meet, well, a larger and especially in the future, chronic and complex care needs for more people?
Mm-hmm. Dear highly esteemed opponent, thank you for that question. In order to answer that question, I would like to give a brief insight into one publication that is currently underway, stemming from the task force that I just presented. What we did is we did a review of European training frameworks for nurses, so both in bachelor and master degree. And we try to then observe how much of a Parkinson nurse is present in those training frameworks, and how much is neurology in general a topic in these training frameworks. And we saw that in less than 50% of all European countries, neurology is included in the training curriculum. And in the case of Parkinson's disease, which is almost a model disease for the field of neurology, as it's so complex and highly individualized, We know that, of course, there are many aspects that are touched upon here that are important and that are already present in the general nursing workforce, which enhance person-centered care, which is also why the nursing profession is so well suited to enhance person-centered and coordinated care. However, there are also some specific aspects that these nurses need to be specialized and specifically trained in. For example, assessing the needs of Parkinson's patients is kind of complex, as you have to know a lot about the disease itself, and you also have to know a lot about suitable local resources. Those are patients that are sometimes really immobile. Those are patients which might suffer from depression, which makes it even more difficult to navigate in the region. And oftentimes also therapy programs targeted for the general audience are not really well suited for Parkinson's disease. So what really makes the need so urgent for a Parkinson nurse is the specialist knowledge they have about the disease and then their ability to transfer what they are already capable of as general nurses.
Okay, thank you. Thanks for elaborating on that. And I would like to address, based on also what you mentioned now, two risks, and I would like to have your thoughts on that. The first one is related to what you just mentioned, and I also saw the evidence you referred to, the specialist role and the necessity, which was published in Parkinson's disease. And you also relate to this. This is a very specific disease with specific needs. And my concern is that we have too much a disease focus. And not, well, in the light of the disability, of the things that can't be done, instead of the abilities of patients. So, and I also see that sometimes with the nursing, with the other roles of the APNs and the physician assistants role, that they have a very strong disease focus. So that would be one of my concerns. And the other concern is, if you advocate for such a specialist role, in fact, you may contribute to fragmentation of nursing and de-evaluation of the profession, instead of what you, of course, would like to do is have more professionalism. So I would appreciate your reflection on both these risks with these specialized roles.
Dear highly esteemed opponent, thank you for that question. I agree with your positions. Just exclusively specializing everything in every disease is probably not the way to move forward. And I would also argue that from the existing literature that I presented in the beginning, those guidelines on the creation of specialist teams for Parkinson's disease, when you critically look into the authors, those are mostly medical doctors. Mm-hmm. So a profession publishing something about another profession, and I know this can be of a problem. This is why I decided to explore this question from a public health focus, starting not from the disease, but actually from the desideratum of person-centeredness. And yes, in that case, of course, this thesis is advocating for professionalization and specialization. However, I agree that when we observe, or when we try to group this thesis here into broader workforce development measurements, we have to take that into account. We cannot specialize our health workforce, especially in an age or a decade of a shrinking workforce, in every single disease. So we carefully have to consider where those competencies should be located. I think a very good example is the United Kingdom. That is a healthcare system where Parkinson nurses are already present. And in this healthcare system, this is a specialization available for community nurses. However, there are some regulations in place that ensure that in a certain district, not multiple Parkinson nurses are located. And I think this is something we have to take into account as well, taking into account the number of patients we have in a healthcare system, and then thinking how many professionals and specializations do we need, and also taking into account that specialization doesn't mean that the nurses give up the other important roles they're taking on.
Okay. Well, thank you for your answers, and I give the word back to the pro-rector. Thanks a lot.
Thank you, Professor Zwakhaal. The opposition will be now continued by Professor Schauler-Oczak, Professor of Intercultural Psychiatry at the Charité in Berlin, Germany.
Thank you very much for the invitation, and thank you to the candidate for this really excellent work and your really well-designed book I have also many things to say in positive, but also in other ways. It's a really great work which you did, and I congratulate, first of all, to you succeeding this really great job. So my question is, the first one is, could you please summarize the main task of an integrated specialized nursing for Parkinson's disease? So it's an integrated approach, interdisciplinary, as I understand, and also personalized. What are the main tasks?
Highly esteemed opponent, thank you for that question. Of course, there is in this professionalization process and describing that role always some room for personalization, I would say, in implementation. However, there are some core tasks. A Parkinson nurse, first of all, is a coordinator. A Parkinson nurse is someone patients can turn to with their questions, but also other healthcare professionals can turn to. They are navigators through the healthcare system. They are experts about the disease, but also required care resources and available local healthcare resources. And they are experts in personal care requirements. Might that be the individual background of the patient? Might it be knowledge about their personal situation? For example, how do they live? Do they have someone to support them in their family? If not, what could we do to support them otherwise? So the main tasks are gatekeeping, coordination, and providing specialist knowledge.
Thank you very much. My next question is regarding disorder-specific issues. So you mentioned that this is an approach for Parkinson's diseases. Do you think that all diseases like insult or other issues, other disorders, need also specific qualified nurses?
Dear highly esteemed opponent, thank you for that question. I wouldn't say that it always has to be a nurse. I would say in chronic care, complex care, and long-term care, the nurse is the best suited profession to fulfill that, as they have such a close connection to the patient, and on the other side, a really good oversight over the care process, especially in inpatient settings, for example. We know from the evidence that nurses spend much more time with the patient than, for example, medical doctors. However, there might be also other disease fields where other professions might be suited for taking on such roles as well. I would argue that yes, complex care settings and complex diseases need specialist knowledge. However, we have to look into case from case, whom do we attribute the specialist knowledge to, how can we integrate it into existing professionalization and training structures in the healthcare system, and what makes sense for the individual context. For example, in Germany, I would argue that for chronic diseases, the nurses are a really well-suited profession. In other healthcare systems, for example, such as the United Kingdom, we also have therapists taking on training, taking on such coordinative roles. And in the Netherlands, we have the PARKINSON'S. This is a national network for training therapists on Parkinson's disease, and they could take on such coordinating roles as well.
Thank you very much for exploring this very important question. What about the informal carers? Which kind of role could they take in your work as integrated, personal-centered nursing specialists? What do you think could be the interactions between you as a specialist and the informal carers, for example, family members and other relatives?
Dear highly esteemed opponent, I would like to refer back to one work that I integrated into thesis for answering that question, and that is the cross-national interview study that we did with 113 patients from different healthcare systems. I'm sorry, I'll move closer to the microphone. And in this study, we allowed severely affected patients to bring their care partners to the interviews. And what we saw from that is that this helped the patients to express their needs. And sometimes we also see that informal caregivers provide additional information on what patients need. Of course, that has to be moderated and that has to be treated with caution, because sometimes your family member have another vision of you than you have of yourself. However, informal caregivers are, for the Parkinson nurse, a valuable resource of information, especially when it comes to, for example, settings of diversity, also settings of migration and ethnic minorities. That is something where cultural is a really important aspect of providing person-centered care. And for healthcare professionals, it's important to recognize those differences. And then informal caregivers can maybe also help to explain a little bit why do they perceive certain things, why they have a desire to achieve certain things. So informal caregivers are a central part, I would argue, in person-centered care planning, and they must not be excluded but included.
Sounds good. Another question regarding diversity, migration. You know that intercultural competence is a very important qualification of professionals in the healthcare system. Could you please explain what is intercultural competence? What does it mean in regard to this specialized function of nursing?
Dear highly esteemed opponent,
intercultural competence.
Thank you for that question. I think cultural competence is a really important aspect of providing person-centered care. In the one study on quality of life that I presented first, we saw that quality of life is also shaped through identity and social life, and that is strongly influenced by culture. We did, back in the time when I was working in Marburg as a scientific associate, we did a study on which patients from which backgrounds do we actually see. And we observed that we rarely saw patients with a migrant background. And that can't be. That there must be a gap in the healthcare system because there is no international evidence that there are lower prevalence rates across different cultural groups, at least not so different than compared to what we saw in the clinic. So there must be a gap. Why do those patients do not reach the healthcare system? Is it because of the language barrier? Is it because the offers that are made are not suited? Is it because they maybe also perceive them in a wrong way? So I feel like the Parkinson nurse here could also be a facilitator, doing almost like a translation job and offering those patients also reducing the barriers for them to reach the healthcare system. For example, we also envision the Parkinson nurse not as a profession that has to be suited or located within a hospital. That can also be a profession that goes out into the community and thus helping also to cross barriers that we have in the German healthcare system at least.
Thank you very much for these really great explanations. One more question is regarding ethical principles. Could you also explain a few words regarding ethical principles in your work? You know, ethical principles are, for example, respect for the person, beneficent, non-maleficent, and treating people fairly. Maybe you can add some aspects to ethical principles in your work.
So I would say, as you maybe saw from the first few slides, a lot of work was done in a qualitative way. And in qualitative work, reflection is a really important part. So I had with my co-authors that did the coding with me, oftentimes mutual and many discussion and reflection sessions, and that was an important part of that. We deliberately decided to go with the desideratum of person-centeredness in order to show the respect for the person. However, that is not something that happens just by saying it, you also have to do it. And that as a researcher requires to always step back, listen, being open. And of course, in my case, I am not a nurse, so I always perceived myself as sort of a guest, a visitor in this field, bringing my perspective to the analysis that I did. But first of all, giving voice to those being affected and giving voice to those working in that field. So one really central ethical principle that I hope to demonstrate also through deliberately choosing person-centeredness is respect for the person, but also openness and of course also transparency were really important through the conduction of all of those research.
Thank you very much. Just now I do not have more questions. If there is time time I can have more questions, just to...
Sorry, but your time is up. Your time is up for asking questions. We have to continue with the opposition.
How many minutes do I...
Thank you very much for your questions. And we continue with Dr. Azopardi Muscat, Director of the Division of Country Health Policies and Systems at WHO Euro in Copenhagen. Thank you for coming to Maastricht.
Thank you. Good morning, dear candidate, and congratulations. And whilst I am sitting here with pleasure listening to you in Maastricht, my team in Copenhagen is actually at the moment holding a symposium on optimizing the future healthcare workforce. And your work, of course, is an important contribution in this regard. Thank you very much. And one of the elements that you touch on in your work, and that, of course, needs to be taken into account when we talk about optimization in view of the scarcity of the workforce and of the demographic shifts that we have in the European region, not least, is how we embrace and utilize digital technologies, including telemedicine, but beyond also. You mentioned the role, for example, in terms of monitoring, remote monitoring. So my first question to you would be, how do you see that these digital and technological competencies can be imparted to professionalize nurses working in Parkinson's and other similar diseases? At what stage in the professionalization, and through what kind of pedagogic means?
Dear highly esteemed opponent, thank you for that question. Actually, in Parkinson's disease, telemedicine is a really important part. Even though it's a non-curable disease, we can, through the use of telemedicine and technology, observe emerging red flags, for example, rising falls, that then can be addressed, for example, through adjusting the medication, having a review of the home environment, and that can lead, we know that by evidence, reduce the risks for hospitalization. So even though it's a non-curable disease, we still can prevent a lot, and telemedicine and the right data can help us to do so. However, there is a central issue here. Technology itself is not the solution. However, technology needs to be, first of all, tailored to the individual patient needs. It has to be a technology that is easy to use for the patients, but it also has to be a technology that produces data that is easy to interpret into clinical routines and that is easy to integrate in those routines. And then we also need professions who are able to read and interpret the data and decide, what do we do now? And algorithms can help us to do so. However, we conducted a study in Marburg where we used telemedicine, and nurses functioned as so-called coordinators, observing the emerging data and then deciding what to do next. And we saw that there is still, despite the use of algorithms, always a small part that is left to discussion. Oftentimes there is not a single solution in healthcare, but there are multiple. And then there needs to be someone who has a good knowledge about the disease and the individual care requirements of the patient, and then who goes into mutual discussions with them, deciding how do we move forward, what do we do next. And that is something the nurses with their specialist roles can do really, really well. So telemedicine needs guidance in implementation and needs guidance in the use of everyday life. And that, of course, requires specific competencies. You must know how to read the data. You must know what decisions to make. You must know maybe also what other professions to integrate into the decision-making process. And that should be, if applicable, a part of really early professionalization, because telemedicine is going to become more and the potential of it is huge, but we need the right, I would say, boundaries in which this technology is facilitated and implemented. However, we also have to acknowledge that there is not just one technology. Competencies that you need vary from technology to technology. It always depends. So there also must be a little bit of a filtering. For example, there are some technologies you can more use in inpatient settings, some you can more use to facilitate community-centered care. And I would argue when we also say that we should integrate telemedicine competencies really early on in the process, we also have to think about what kind of competencies, and at some point it always depends also a little bit on what technologies are used.
Thank you, and thank you also for highlighting the complementarity rather than substitution of the roles. And this brings me to my second question, which is, do you have any evidence of fear or resistance from the professionals because they feel that technology could dehumanize the care? Has this emerged in any of your work so far?
Dear highly esteemed opponent, yes, we observed that. In one of the last few slides, I presented the 2 case studies, and that was actually a big project where we implemented the role of a specialist nurse in different European healthcare systems. And then the nurses worked as so-called care coordinators. So they defined care priorities with the patient and then helped them to navigate through the healthcare system to reach that goals they had. And telemedicine was an important part on that. And through an online survey, we interviewed the nurses about their perception of telenursing. How do they perceive their role in it, and what facilitators and barriers do they perceive? And some things that also emerged from that younger nurses perceived it a little bit more easy to use those new technologies, and elderly nurses had a little bit more of a struggle because some said, this is almost a one-on-one quote, I was not born in a digital age, I have some issues to understand how to use the technology. But what we also saw, if the implementation of these technologies is guided by a good training framework that really substantially helps to reduce barriers, and what also has to be there are the right organizational structures. So an organization that gives the nurses time to get used to the technology, contact to other professionals and colleagues to ask questions. How do you do it in your setting? That didn't work. How can we solve it? And so on. So yes, there are also barriers in terms of a little bit of a fear of technology, sometimes observable, but the right context can help to reduce those significantly.
Thank you. One last question from my end. On page 160, and I quote, you say, contrary to the expectations, no evidence was traceable that personalized care models improve the quality of life of patients with Parkinson's compared to standardized care. In a situation where all health systems in the European region are coming under tightened fiscal space concerns, how do you think that it is possible to advocate for this specialized care to insurers, funders, and policymakers in the face of such a statement?
Dear highly esteemed opponent, so the quote you were referring to is conclusion from the meta-analysis we did on randomized controlled trials comparing nurse-led versus standard care models on personalized Parkinson's care. And in this meta-analysis, there were only very few studies included, and thus we couldn't conclude that based on the statistics, there is yet a significant effect. However, in the discussion, we mentioned that this doesn't mean that person-centered care is less of an effect. That means maybe we need also more evidence and the right studies on it. Because right now, the central outcome in those studies facilitated is quality of life, measured by a tool that we also in the first publication in this thesis criticized a little bit because it's a quality of life tool measuring only disease-related aspects. And we see that person-centered care is affecting much more, and patients perceive quality of life in many more dimensions. So maybe we also have to think, how do we actually measure the effect of what we are trying to achieve? And of course, because the nursing role is yet so under-researched in that field, we also have a huge heterogeneity between included studies. So maybe for the future, we need also more harmonization and standardization of the protocols that we try to research then. So I wouldn't say that this is an implication, this has no effect. This is more for us, a researcher, a call to action to go further, to not give up, but actually this is an identification of a knowledge gap that it's worth to address.
Thank you.
Thank you, Dr. Azzopardi Muscat. The next opponent is Dr. Zietz, Assistant Professor of Comparative Health and Health Policy Research at the Department of International Health of Maastricht University, but currently in Krakow.
Thank you very much for the floor. Dear candidates, congratulations. First are in order on an excellent thesis. And of course, I would also like to congratulate your supervision team. While I really enjoyed the thesis, and I think it's an important milestone, I would also like to get some more insights from you on how you made some decisions regarding the methods and how you think about the implementation of the competency framework and profiles that you developed. So first, if you allow me to start with the methods, my first question would be regarding the pragmatic paradigm that you employed. So the question is, how did pragmatism guide your decisions about when to use qualitative versus quantitative methods? And did you ever face tension between a purely pragmatic stance in your research and the demands of rigorous theory construction, which you were also pursuing?
Dear highly esteemed opponent, thank you for that question. So actually, one of my propositions is also a quote by a very famous pragmatist, William James. It's the last proposition. And pragmatism stands for an epistemological standpoint that I deliberately chose in this thesis. William James, with his quote, is actually saying that truth is not ultimate. It depends on its usefulness. And back at that time when he published that, he was really in the literature, there was a huge debate about his position because philosophists didn't really like his standpoint. They said this was too simple, this is too ordinary, this is not the right way to move forward, philosophy is so much more. And I would say in this case here, when we talk about workforce development, this is this is pragmatism in action, what this thesis tried to do. This thesis tried to generate knowledge, which then was judged by its usefulness, by its impact it could have. And this decision guided me through all of my choice of methods. So what I always wanted to do, I didn't want to impose my own perception of the reality, but I wanted to give floor of the truths and individual realities of those being affected. Might it be through the patient interview study, of those working in healthcare, might it be through the focus group study by the nurses. So I aim to explore different perspectives and then try to bring them together to see how can we perceive one common thing, person-centeredness and the role of the Parkinsoners from different realities and different truths. And that guided me also mostly in choosing qualitative methods, as my approach was to observe perceptions and observe different realities and give also space to interpretation.
Thank you. Did this ever lead you into a position where it would be difficult to use the insights that you've gathered to inform theory construction, however, right? It could be, I mean, of course, I understand that you wanted to give floor and space to truth from various perspectives and various sources. But on the other hand, in order for us to construct rigorous theories, there are still certain principles of scientific validity we have to pursue. And it might be challenging to do that if we really have a lot of very disparate and very heterogeneous sources of evidence.
Dear highly esteemed opponent, thank you for that question. We constructed a theory, so it's a good thing. We can maybe dive into that a little bit. That was in the publication on the theoretical framework. And in this study, we decided to stick to Lindham's growth cycle of applied theory building. And Lindham proposes that theory building is not a linear process, but it's a cycle of observing, abstracting, defining, implementing, refining. And theory building can start basically at any point in the cycle and continuously grows through going through that cycle. And in this thesis, I tried to touch upon many different dimensions of Lindham's cycle. First of all, I conducted the interview studies, which is more of an observation. I conducted the systematic literature reviews. This is also sort of an observation. Then the theory framework, we implemented that, trained some nurses according to the theory framework, that's implementation. And also in the discussion then where the big framework, the last slide that I showed on the competencies and roles of the Parkinson nurses, that's almost a refinement. However, I acknowledge that this process is not done yet, right? It would be sad if we could now stand here and say as of today, okay, the cycle is closed, we finished everything. I would say there's still much more to do in the future, certainly. In order to improve the theory of the Parkinson nurse, I would like to see even more implementation. This is currently what we're trying to do with launching a study program in Germany, and then coming again to the refinement, checking, does this professionalization now have any implications for how we theoretically perceive the Parkinson nurse? So I wouldn't say we haven't achieved anything, but we're certainly not done yet. This is a part of the cycle that still grows and hopefully becomes even bigger in the future.
Thank you very much for these reflections. I would like to change tack a little bit and ask about the implementation of the competency profile you developed. You proposed say, one Europe-wide competency profile, right? And I think that's definitely the way to go, and it's a very good idea. However, it might be challenging to implement a so-called Europe profile when dealing with very specific national health system structures, specific national regulations. So how do you envisage dealing with these kind of local implementation issues?
Dear highly esteemed opponent, in order to answer that question, I would like to refer back to the desideratum of person-centeredness, which always requires some adaptation to the context. And I would say that doesn't only account for the care process of the patient, but this also accounts for implementing the role of the Parkinson nurse. I acknowledge that especially in lower income countries, it might be difficult to implement an entire specialization role. However, that doesn't mean that we cannot implement those competencies in this healthcare system. Maybe we just need to rethink a little bit, right? Maybe we don't need to have an entire education program on the professionalization of the Parkinson nurse, but what we saw, I briefly touched upon this in the beginning, from this EU comparison that we did on nursing curriculums, there is much more room for improvement, for example, in order to integrate neurology and even Parkinson's disease into broader curriculums. And maybe there's also some possibility to integrate some of those competencies in the broader nursing workforce. Why not? So I would say it always depends on the healthcare system, what is suitable, what resources are there. And just because an entire professionalization of one specific role, specialized nursing role, is not possible, that doesn't mean that nothing can be done.
I couldn't agree more. Thank you very much for these reflections and answers, and I return the floor to the prorector. Thank you very much.
Thank you very much, Dr. Zietz. We now come to the last opponent, Dr. Van den Bulk, with expertise on the organization of home care nursing at the Department of Health Services Research of Maastricht University.
Thank you. Dear candidate, congratulations to you and your team on this thesis. And thank you very much for your beautiful presentation. You have succeeded in exploring this not very often studied field, and seeing from your impact, it really had impact. So good job on that one. I would love to reflect with you on several aspects of your work. And to start with, I want to start with a short question, because I was wondering, what do you think actually is the main reason that the number of Parkinson nurses is so low?
Mm-hmm. Dear highly esteemed opponent, that is a short question, but maybe not a short answer. That is really complex. I would say it has different reasons. Let's start in Germany. In Germany, the nursing role is yet still an underrepresented profession in academization. And so in research on nursing, there is limited research that stems from the nurses itself. And because we have so little nurses specialized in Parkinson's disease present yet, there is even less research coming from Parkinson nurses. So to some extent, there is, because of that, and because we had a few years back no really connection among these nurses of each other, there was a lack of mutual communication. So them standing up and saying, we are Parkinson nurses, we stand for that, and we need that, and we're doing this. And I think this is one aspect that plays an important role here. And European-wide, we also see that, for example, on big congresses where also academization and policy-making come into contact with each other, this profession is not really present yet, and nurses in general. This is, for example, why the first thing that we decided we need to do in Germany is to establish a nursing day at the biggest congress for neurology in order to make that visible and demonstrate this is an important part of the neurological workforce. And I think in that case and in that sense, there is much more to do and much more space to move forward. And also for us as public health research, workforce development is not yet such a big topic in every part of public health workforce and public health training. And this is certainly also an aspect we maybe need to improve.
Thank you. Well, that perspective of the public health is quite new to me, but having a background as a district nurse myself, I mean, it's obvious that care is getting closer to home more and more. And I noticed from chapter 4 that you're also working towards a practice nurse that is more home-based. And could you elaborate a bit more on why this is the most suitable setting for a Parkinson nurse to work in?
Mm-hmm. Dear highly esteemed opponent, we saw that social life and identity are really important aspects of quality of life. And this is especially for this generation and the patients that we interviewed. The home environment and the feeling of independency is a really important aspect of that. It was frequently mentioned. I identify myself as someone that is part of this community. I still want to participate. However, I feel my disease is blocking me from doing that. And in order to help those patients regain their ability to actively participate in the community and the social life they're living in, we cannot provide healthcare outside that community. We have to integrate that community. In some European countries, we also still observe a little bit of a stigma around Parkinson's disease, and so the Parkinson nurse, in that sense, being a part of the community, also fulfills educational purposes, showing to the community what Parkinson's disease is, how can we still facilitate integration for those people, and also helping the people to reach the healthcare resources they need. In Germany right now, we have unfortunately a situation where patients sometimes have to drive 200, 300 kilometers to get specialist care. That is not working for severely affected patients. And in that sense, the Parkinson nurse can also be someone bringing those specialist care to the community by providing their expert knowledge in the community. I think this is a really important part, and this is why I postulated that in chapter 4.
And where would this Parkinson nurse then be based? Because is it then a specialization of district nursing, which is already a specialization on itself, or is it more that you see them based on the social care side?
This is probably up to discussion in a specific healthcare system. We had a huge discussion about that in our task force on the German healthcare system, and I personally would envision the Parkinson nurse not being someone hired in a hospital, as it's right now mostly the case. I think it would have huge potential to have them located, for example, at local healthcare authorities. This is currently not really implemented yet. In the United Kingdom, we see that Parkinson nursing is a specialization for community nurses, community district nurses, and that works really, really well. In other healthcare systems, for example, Switzerland, Parkinson nurses work in the hospital, but they work as independent profession. So from the hospital, they can provide, for example, consultation outside for the community. But also in Switzerland, they have much more of a connection between the hospital and the community around the hospital. So there are a plethora of opportunities to integrate the Parkinson nurse. It would depend on the healthcare system, I say.
I would totally agree. But seeing it from like the many professionals that are involved, and also having that a more integrated care perspective. For example, in chapter 2, I noticed that you saw the GP as a coordinator. But for example, looking at this perspective from a GP, which is also not present in every healthcare setting, won't it become more and more complex for someone as a GP, adding a new layer with a Parkinson nurse to this already huge setting with lots of different professionals involved? Wouldn't it become even more and more complex for such a professional to coordinate? And could you reflect on what that then would mean in collaboration with all those professionals?
Dear highly esteemed opponent, thank you for that question. That actually goes close to my heart, because right now I'm working at the Department of General Practice. So I know as well the perspective of the nurses really well, but I'm also having insights into general practice in Germany. And yes, I agree. For a general practitioner, it's really, really complex to have all of those opportunities in mind. And it's not always possible for every disease as a general practitioner to know what resources are there, who can I connect with whom, and so on. However, in the field of Parkinson's disease, we have a good solution for that in Germany, and that is technology. There was a really interesting research project working on so-called quick cards. That is a card that goes with the patient through the healthcare system, where different providers can then check what they observed in the patient. And that entire process then, for example, could be guided by a Parkinson nurse who frequently reviews those quick cards, sees what different healthcare providers observed, and then based on that works as a connector. Why not? And that can also help to reduce the burden on other healthcare providers currently fulfilling the role of a connector, for example, the general practitioners.
Okay, but like having even this large package of the different roles you have as a Parkinson nurse, because that's what you studied in chapter 3, wouldn't it be more logical that that Parkinson nurse would be the one coordinating care, like working with the car, and instead of laying that role with a GP?
Mm-hmm. Dear highly esteemed opponent, yes, that would be great. In order to do that, we might need to change some laws in the German healthcare system, but why not? This is an implication I would like to draw upon from this thesis as well. We maybe need also to change context in order to enable professionals to facilitate their entire potential, so to speak. So yes, I would say that would be good, but we also need to set the right frameworks. For example, in Switzerland, nurses can work also independently, and there it's possible for them to also fulfill this connector role. Yeah.
I'll keep it short for you.
Yeah, thank you so much.
Marlena van Munster, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Get the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
Marlena van Munster, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Chabanovska is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Please, all right.
Thank you, Professor. Dear Marlena van Munster.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
I promise.
By the authority vested in us by law in conformity with the decision of the committee here present, I hereby confer upon you, Marlena van Munster, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and other members of the committee, and affixed with the official seal of the university.
Thank you. Please be seated.
And now the pleasure. On behalf of the supervisory team, Professor David Pedrosa, Dr. Timo Clemens, and myself, I feel privileged and delighted to give this laudatio to acknowledge your scientific achievement, which is a PhD degree from Maastricht University. We, and I, am grateful that we could assist you up to this day when you have blossomed as an independent researcher and academic. It is a pleasure for me to recognize, admire, and reflect on certain qualities which shine and make you special. Dear Marlena, these are scientific curiosity, academic integrity, professionalism and authenticity, ability to challenge yourself and go beyond the comfort borders of self while doing research, ability to work very hard and change your projects into treasures. You have shown a research diplomacy and foresight, very good scientific communication, but above all, the ability to develop comprehensive solutions, integrating many approaches at the intersection of theory, practice, and policy, which have been inspired by new knowledge and learning, of which your PhD thesis is a beautiful reflection. I got to know you as our master's student, who chose a very complex and challenging topic for your thesis. It was obvious that you have a research drive. During your work in Marburg, you naturally turned an opportunity of working on the research project in the area of Parkinson care into a robust PhD thesis, which resulted in many renowned publications in focused scientific journals. I extremely value our conversations during which you were sharing with me your research dilemmas, to which you were always able to find good solutions yourself. Dear Marlena, you are always one step ahead of scientifically curious and move towards an innovative solution by bringing people, ideas, and topics together, for example, competencies, care models, regulatory aspects, which in your thesis contribute to the recognition of and add professional value to Parkinson's care. You developed as a scientific leader. You have a vision, and you have created a roadmap to implement your vision. I'm proud that I have accompanied you and seen you grow in leading self in science with great motivation and passion, leading others who were partners in your teams by engaging them and valuing their input. You have also volunteered to help our students grow by serving as a mentor in public health program, being humble in your approach, both learning and giving support. With this PhD thesis on professionalization of the Parkinson nurses, your academic and professional experience, you have grown as a leader who will be able to take up various organizational responsibilities, both in academia, research institutes, or other organizations. With your background in public health, governance, and leadership, blending strong research base with the sensitivity and empathy, you have contributed meaningfully to build and strategize the knowledge base for Parkinson's care. Dear Marlena, you deliver high-quality achievements in public health. We are proud to have assisted you on this journey to reach this special day. Congratulations to you.
Thank you so much.
And your family.
Dear Dr. van Munster, also on behalf of Maastricht University, I congratulate you with the degree you have acquired. I also congratulate your family present here, maybe also online, friends, colleagues who one way or the other supported you during this PhD trajectory. I also like to congratulate your supervisors present here and online. I'd like to thank the members of the degree committee for coming to Maastricht, being in Maastricht, being online. Thank you very much, especially our guests from outside Maastricht, Dr. Azzopardi and Professor Charlo Oczak. Thank you very much for your contribution. During your PhD defense, you showed that you are not only confident on the topic that you studied, but also very knowledgeable. And I must say, I do a lot of these PhD defenses, but I've seldomly seen someone who seemed so relaxed and on top of everything as you, although of course I don't know whether you really felt that relaxed. But anyway, it's now time to relax and enjoy the fact that you obtained a PhD degree from Maastricht University, and I wish you a lot of success.
Thank you so much.
And hereby I close this academic ceremony.
Dr. Marlena, please come forward.
I'm from Dr. Rok Orcic. I cannot pronounce your name.
I'm Slovenian, but otherwise,
Come a bit forward
I'm Slovenian.
so that everybody else
Ah, okay, you're in Slovenia.
Recording stopped.